Welcome to Health Law Talk, presented by Shahardy Sherman Williams. Health law broken down through expert discussion, real client issues, and real-life experiences. Breaking barriers to understanding complex healthcare issues is our job.
Good morning, good afternoon, whatever time it is you're listening. Welcome to another episode of Health Law Talk here. Conrad, Meyer, Rory, Bellina. Rory?
Welcome back. Thanks for listening.
Absolutely. Interesting, Rory, today, 77.6% physician employment rate, 300,000 AI denied claims in 2 months, the largest hospital bankruptcy in history. If you told me 10 years ago that more than 3/4 of American physicians would be employed by hospitals or some corporate entity, or that insurance companies would be using AI, right, Jarvis, like to deny claims, 300,000 claims in a 2-month span, and that private equity firms are going to drive the largest hospital bankruptcy in the United States history, I would have said you're crazy.
Yeah.
Crazy.
It's taken a while to get here. I think none of this has happened overnight. I think we could all recognize that, but there's been big shifts, and over time, probably about 10 years or so, I would say a lot of these have been implemented. That's how we get to where we are now.
So today we're doing something a little bit different than we normally do. We're going to go look at 10 years, a full decade of American healthcare, and see what has changed. We're going to talk about basically 5. I know there's more than 5, but
sure.
I don't have enough time to do more than this. But so 5 forces that have fundamentally reshaped how medicine is practiced in this country, which include declining reimbursement, the explosion of administrative burden by physicians. We're going to go into that.
Yep.
AI insurance denials, the shift from the former independent practice to employment model, and of course, corporate and private equity takeover.
Yeah. All right. Well, let's start. Let's jump right in. I think we should start with reimbursement. I think that's probably the biggest one that is probably the most important to talk about.
Absolutely. So it all begins with the paycheck. I agree with that. Yeah. And like most people, physicians want to get paid. So in 2015, Congress passed the Medicare Access and CHIP Reauthorization Act and MACRA.
Yep.
Right, we knew of as MACRA. And it was, again, bipartisan, celebrated, talked about permanently repealing a dreaded growth rate formula for Medicare, and threatened basically a 0.20% payment cut at the time. So MACRA was the end-all, be-all of how we stopped the train.
Yeah, and it did give somewhat of an annual increase, going back from, I guess, 2015 to 2019, but then it kind of stabilized, especially during COVID, early COVID, from 2020 through 2025. That update was at 0%, no adjustment for inflation, no cost of living increase, nothing. So that was a problem.
It was, and look, the number that tells the story, the Medicare conversion factor, the dollar amount that converts the RVU, relative value units, into actual payments,
it's gone down.
Correct, gone down. That's basically a 9.6% nominal decrease.
Yeah, my notes show that it was at 35.80 in 2015, and now it's down to roughly 32.35. So yeah, about 10% decrease. Yeah, but that doesn't.
But it's not like the cost went down.
No, and then when you adjust for inflation, that's almost now like probably 33%. I would say going back 25 years.
Now here's the kicker. This is what gets me, and this is really interesting. Hospitals get automatic annual inflation adjustment. Medicare, nursing homes get it.
Yep.
But what about physicians?
No, nothing tied to inflation. No, I know hospitals have gone up. Our notes were showing over 70% over the past 20 years. Physician reimbursement, though, 26% decrease.
So look where it's pushing physicians. That's, again, another employment.
This kind of gets into another topic, but yeah, out of the private practice world and into hospital employment, because that's where the money is.
Right. So, and look, we need to talk about Louisiana specifically. Yep. So Louisiana Medicaid historically paid physicians about 73% of Medicare rates, which is already low, right?
So Medicare is low, and now Medicaid is paying 73% of Medicare, And so we're now 3 tiers down on where probably the rate should be.
Well, interestingly, in July of last year, the state increased it to 85%. So with plans to trying to reach 100% by 2027, 2020, they had to.
Right.
Or are you going to have too many physicians opt out of Medicaid? So again, it goes back to a long time ago about, do you really have access? Right, with coverage.
Yeah.
So I mean, I'm just saying. So
do you have access, or do you go to the ER model, the emergency model, where you're
which nobody wants.
No.
Nobody
I know that
wants.
was a couple of weeks ago, but no, that's
so we're heading in the right direction. You saw adult primary care visits jump about 31%. But when your baseline Medicare rate is already declining, right, for physicians, and you've got an 85% Medicaid rate shrinking, it's still a problem.
Yeah.
So hopefully, I mean, we'll see. It's going to be interesting.
I know there were some increases in the One Big Beautiful Bill. It was a 1 year, 2.5% increase, but still, it's very low. So, I think that the takeaway is that there's been a nominal decline in that Medicare conversion factor, the inflation-adjusted decline since 2011, and there's just a huge gap between the practice cost versus the payment cost. And like you mentioned, hospitals are getting reimbursed. They've gone up 70%, while physician practices or physician pay down 26%. So
and absolutely, look, Congress keeps on applying Band-Aids. I get it. In 2023, they reduced the a planned 4.5% cut to 2%. So they see the tsunami coming. 2024, they did a temporary 2.9% update for that year. And so in 2026, with the big, beautiful bill that we just heard about, they gave a 1 year, 2.5% bump. But these are all temporary.
Yeah.
So really, what are you hearing from your clients when we talk about this, if anything, about these decreasing reimbursements? How do they handle the year-over-year cuts?
Sure.
What's driving them?
I think my takeaway before we shift over to the next topic, because I know we're limited on time with a lot of topics to cover today, is that I'm seeing more and more physicians, especially out of residency and fellowship, going straight into the hospital setting.
Right.
And I'm seeing less and less 10 to 15 year physicians move from the hospital to start in their own practice. Like I'm just not seeing a lot of practices start up as much, and I'm not seeing a lot of practices bring in a lot of groups anymore. It's really going the other way. The hospitals are getting bigger, and I think the private practices are getting smaller.
And our next segment now, this is going to be interesting. This ties into it. So when you've got the administrative tsunami here, when physicians really are just simply billing entities.
We talked a lot about numbers in what we just covered on the kind of the reimbursement side, but I think the latest study I pulled this for our notes was physicians spend only 27% of their day on clinic time with patients. So 27%,
right?
Yeah.
So what's the other 75? I mean, that's crazy.
I would presume it is all, I'm not sure, but I would presume it is all documentation, billing, catching up with medical records.
49%. You saw that?
Oh, yeah, 49%.
49% on EHR work. And interesting, the numbers, 36.2 minutes on EHR per visit.
Yeah.
So they're spending 36 minutes on the EHR. Now I'm wondering. I know
this was covered in an episode of The Pit. Actually, there's this.
Was it? That's right.
There's the young resident who is like,
we do not get paid for the Pit. We don't. But it's a great show.
But it brings up current topics. There's that one. I guess she's a second-year resident now. She is like, they keep hounding her for being behind on her charting and dictation, and she's not seeing patients in the ER because she's sitting behind a computer dictating notes.
So interestingly, who suffers here? The patients do. Right?
Absolutely.
The patients suffer. I mean, I think with the Commonwealth Fund calculated that the primary care physician would need to work literally 27 hours a day to complete all the recommended tasks and documentation requirements.
Yeah.
That's insane.
Yeah. And there's like you said, there's not time to do it. And I think for so long, physicians had a job where it was considered that you go in the clinic, you treat your patients, and you go home. But I think there's definitely been a shift from that to where I know my physician provider clients are telling me that when they get home and after dinner and their kids are going to sleep, they're hopping on Epic and they're trying to catch up on notes, which
that's crazy.
That's not what they signed up for.
And so right into that, and we're going to talk about burnout in a little bit,
Yeah.
but prior authorization has exploded. If you look at it, the 2024 AMA survey, the average practice completes 39 prior auth requests per physician per week.
Yeah, so who's doing that?
Right. And who's reviewing that?
Right.
Who's reviewing it? Who's doing it? That's a third of a full work week just getting permission to treat patients, get paid.
And then you have the issue where the prior auth gets denied, and you've got to do a peer-to-peer, and you've got to schedule that and take an hour out of your day to schedule and get that done. So here's an interesting stat that I pulled. This was from MGMA's 2024, one of their reports, that 92% of medical group practices have hired or reassigned staff solely for prior auths.
That's crazy.
Just for prior authorization. So now you've got someone in your office who could be a nurse. They could be doing triage and rooming patients, but now they're on the phone with insurance companies fighting for prior auths.
I just think it's crazy. So when you look at the numbers, right, it's just nuts. So not only do you have the prior auth numbers, but 40% of total hospital expenses are administrative. That's crazy.
Yeah.
That's so the administrative burden, and then it's funny. I had a graph where I was talking about hospital administrators and their boom over the last decade, which has been, the joke around physicians that I talk to is how many administrators do we need to run a hospital?
Right.
And laughingly, I mean, me being a former administrator, kind of I laugh at that.
Right.
But the burnout is real. The burnout is real, and the staffing costs are real. So now we're having a billing tsunami.
Yeah, so I think what ultimately happens is that you've got less patient care, then you've got less doctors because they're getting burned out with this, and they're just not. They don't have the time in the day to treat in clinic and then go home and catch notes. So it's a double-edged sword now.
They can't do it.
Right.
They can't physically do it. So interestingly enough, 62 to 63% of the physicians cite too many bureaucratic issues as the number one case for burnout.
I agree with that.
I can't disagree with that.
Absolutely. I think that's very fair. I think the biggest problem, and we're going to get into it, is AI and these claim denials based on AI. But that's probably going to even make things worse because these AI systems are, could possibly have a bias to them on the hospital side.
But then again, you have to ask the question about insurance companies because when you look at the numbers, right, 83% of the prior auth denials that are appealed succeed.
83%.
83%.
So that should tell you that these are being denied
like systematically.
Yeah.
Like systematically.
It's almost like an automatic denial and then appeal and then you'll get it.
But here's the scary part. Only 18% of the doctors appeal. So it's almost like a purposeful, systematic way of saving money by purposely denying prior auths, forcing doctors to appeal, and hoping that no more than 18% appeal so they don't have to pay. That is just insane.
Yeah. And
how is that not? I don't know. I mean, that just sounds fishy to me. I'm sorry.
It does. It absolutely
just the
does.
number, like, is that a DOJ thing? Like, I mean, doesn't that sound? I just find wild.
Yeah, I think that's a Congress thing, but you know how this all goes. These insurance payers, they're not gonna.
The machine that runs the lobbying groups.
Yes.
Yeah, we can have a whole. Whole segment on that.
So let's stay on that topic about the AI claim denials because that everyone is using AI.
It is.
Every industry is using AI.
They are.
So how is AI affecting claims? Because I think it used to be in the past where you submit a prior auth, it goes to wherever it goes. And it was landing on a person's desk or a person's screen, right?
Yeah.
And there was an actual person that was reviewing it. I think those days are gone.
I agree.
Well,
look at the numbers.
Right.
83%. I mean, look. So in other words, if you have that kind of a success rate where you're 83% of your prior auth denials are succeeding and overturning, that to me tells me the insurance company better wake up because there's a problem.
Yeah. Absolutely.
That's an absolute problem. That's a systemic problem. That's not right.
No. So United Healthcare, this is one of the ones that I wanted to talk about. Their algorithm, I believe it's NH for NaviHealth Predict. That is what United Healthcare Optum, which is their subsidiary, acquired that for $2.5 billion. And that algorithm is designed to help with post-acute care and SNFs and rehab centers. Supposed to help with it. Right. But it was supposed to be a prediction, but it's really not. It's more of a dictation now. And then there's been some challenges to that.
Well, I think it's again going back to the systemic issue now on talking about AI claim denials, which I think is important. I think insurance companies are banking on people not appealing.
Oh, absolutely.
Don't appeal it. We're just going to outright deny it. And I mean,
only 18% are going to do it.
They're going to do it. So we're going to get
4 out of 5 are going to fall off.
We're going to have an 82% success rate on no one's going to take it further, right?
Yeah.
And so it's just to me it's baffling. Yeah. Why are we paying for? I mean, this is what you're paying for,
right? You're supposed to be paying for coverage, but no, that's frustrating. That's very
so. The
frustrating.
business model itself works because only 0.2% actually appeal the claim. They don't even do it. These are people, not doctors. So
right.
So basically, even with a 90% error rate, right? Admittedly, 90%.
Yeah.
The math favors the insurer.
Yeah. I know that. I mean, in like I know we briefly talked about that at NH Predict, and there was a case involved in that.
Yeah.
But it's not just United. I know Cigna has something as well that automatically matches procedures
PXDX
against diagnoses and then denies the mixed matches. A report came out though when I was doing the research for this. It explained that Cigna denied 300,000 claims in 2 months.
That's insane.
300,000 claims in 2 months.
Imagine
300,000 claims couldn't have gotten processed in a year if this were actually going in front of people.
Correct.
But when you've got these LLMs that are running these claims, they could process much faster. But no, there's no way. There's no way.
Did you see the doctor from Cigna?
No, what did he say?
He's basically if you took the 300,000 claims,
right,
and just ran the numbers in 2 months,
okay,
that is literally 1.2 seconds.
So it's
who can read? Like it doesn't make sense, right?
So the computer's doing it.
Right,
they're not. So I think gone. Gone are the days when you submit a prior auth or a claim and someone is on the other side actually looking at it.
So
that's done.
When you pull the curtain back, it's not being reviewed.
No, absolutely not.
It's not.
It's physically impossible based on these numbers.
It's a rubber stamp to say deny.
To do it. And it's a lot cheaper from these insurance companies' perspectives to pay for these servers and this software to do it, and then if there's an issue, well, we'll deal with that. Then a person will deal with it.
And then you know what? It's great. The plaintiff counsel, the plaintiff attorneys have picked up on this, and they're going after them.
Oh yeah,
they're going after class actions. I think Humana has one.
Yeah.
This is Barrows versus Humana in December 2023 that basically alleged that Humana employees who deviate from the algorithm projections, they're disciplined and terminated. How do you like that?
Yeah. There was one against United where someone was denied SNF. He ultimately passed away, and I think the estate finished with the lawsuit. And it was actually, this one was unique. It was a breach of contract over his policy, because I believe the policy language said specifically that the coverage decisions will be made by clinical staff or physicians.
Well, let me tell you,
not clinical staff or physicians, though, not an algorithm. And then if you appeal,
well, look, I will tell you, 2024 CMS recognized this. They stepped up and issued some regulatory guidance that said that algorithms can assist in coverage determinations, but they cannot solely dictate coverage decisions.
But that's too gray to me.
I think it's gray too.
I think
it's
that
not enough teeth.
Solely, because you say it cannot solely dictate.
What
the
does that
decision
mean,
must
right?
be based on but that tells me that if you have someone that just glances over it very quickly, the algorithm didn't solely do it. I think that's not enough. I know CMS probably doesn't.
Well, it's not just CMS. So states are not getting involved. You saw California.
California has a
SB 1120.
Yes, they have a big one for AI, and that was denying or modifying coverage based solely on an algorithm is prohibited in California, at least.
And look, other states are coming. Arizona, Connecticut, Maryland, Nebraska, Texas, all have passed similar restrictions.
I think Louisiana, my notes show that it was House Bill 114. That was from last year. Same thing, same concept as California with civil penalties in place.
So the scale of this is crazy.
Yeah.
It's crazy. 53 million prior auth requests were submitted to Medicare Advantage programs just last year.
Sure. So my question, though, for you,
so that's
is,
like imagine the automatic denial of all that.
Right. My question for you, though, is the numbers of prior auths, let's say they're relatively the same. Maybe they go up a little bit year over year based on just having more patients.
Claims data, right?
Right.
I'm with you.
Let's say that's the same. So they're getting, at least with the AI algorithm, these claims are getting processed faster. Now they're getting denied faster, but is there any benefit to patients that at least their claim that would have taken 6 months for a human to review, it's now getting denied in a week, but then you start my question to you is, do you think there's any benefit to the machines that, hey, we know it's going to be auto denied, but then we're already ready for the appeal?
Why? No, I don't know. I don't think it's any benefit because they're banking on people not appealing. They're banking on people not appealing.
I agree with that.
On doctors not appealing. So I think it's built into their model.
I agree with that, but my point is it almost faster now for the AI model to auto deny you, and then you get your appeal maybe even faster than you would have gotten it initially reviewed by a person under the old model?
Here's my question.
I'm trying to find a silver lining here.
What silver lining? What are you paying for? I mean,
that's true.
What are you paying for? Would you want to, like, for, let's just say this? How about this? You go lease a car, right? You're paying every month for that car.
Yeah.
What happens if the auto dealership just says, we're going to have that car fail automatically in a month on you? And then you're like, but I'm paying a lease payment.
Right.
Shouldn't you do something? No, because the failure is going to be outside the scope of the lease. You're just going to have to, or you're going to have to appeal to us.
You'll have to appeal it, yeah.
Right. I mean, are you kidding me?
No, I'm just.
So it's the same, it's maybe not the greatest analogy, but I mean, it is, I think it's, if you're paying a premium for coverage.
Right.
And you're paying good money for that. That's people that pay hard-earned money.
Right.
Should they be subject to an automatic denial when their health is on the line?
No, they should not be. And I think the goal behind using AI on these claims was to speed things up. And my only point was, is it speeding it up to where maybe you're getting your result you have to go through another step, but you're getting your answer faster. I don't know.
I think the systemic denial on prior
that's
auths
a problem.
is a problem.
I completely agree. I agree with that.
I just don't know. I can't see the silver lining in something that hard-earned Americans have either earned or paid for, to have them simply auto-denied by Jarvis, Jarvis, or whatever AI you're using, whatever algorithm, whatever acronym you're using. I think that's a travesty. I do. And enforcing those people to do that, So, and enforcing doctors to do that, right, and spend all that time, now another reason why you're not seeing these independent practices. Yeah. So, another reason.
Well, let's talk about that. Let's talk about independent practices and why it's so harder. It's so much harder now for an independent practice to survive. Well, everything we just talked about has all takes, like in the last segment we just mentioned, you're hiring more and more staff to handle these auto denials and these reviews. So
wait, think about this though, the tsunami, right?
Yeah.
Declining reimbursement.
Right.
Overburdening administrative EHR documentation to just
lower reimbursement rate,
auto denials.
Yeah,
right. So what's an independent practice look like if they exist?
I think it's very hard. They probably have a very high payroll amount because they're having to deal with all these things now. Hospitals can handle that. Hospitals can absorb that most likely because they probably are using AI themselves. But a small practice, that's why we're seeing the.
Then you have to fight hospital, in terms of compensation, because again, hospitals have been getting the auto increase, doctors haven't,
and they notoriously pay
more. Well, they pay lower. Well, what I'm saying is that the hospitals are able to afford to give physicians higher compensation. So so it's driving doctors out of practices into hospitals because practices can't compete with systems on reimbursement. Why? Part of the reason is because CMS is not giving the physicians the bump
Yeah.
as hospitals. That's part of the reason. And then you've got all the administrative stuff we talked about. So
Yeah.
it is, when I tell you it is a unicorn, it is not for the faint of heart for a physician to try to go out and do independent practice.
So 2012,
Yeah.
60.1% of physicians were in private practice. So a little bit more than half. Okay.
Yeah, and look at it now.
12 years later, the latest data, end of 2024, it's down to 42%. So a loss of, call it 18%.
Almost 20%.
Decline in 12 years. So you're losing about a little bit more than 1% every year. We've lost about 1% every year.
Oh, more than that.
77% of all physicians are now employed. So,
And
we
so
had-
by some corporate machine. Now, put that in perspective.
Yeah.
Whether or not whatever you think about that.
yeah, and I think there was a huge acceleration in it during COVID. I know that there was a big increase in employed physicians because the hospitals needed it, so they were paying whatever they needed to pay, and that kind of changed the market.
So who loses out even more? I think rural areas
absolutely.
really get hit. I mean,
Yeah.
you're talking about rural hospitals where the number of independent doctors have declined literally by 43%.
Yeah, so the same metric from 2019, there were about 20,000. Now we're down to about 12,500 as of the 2024 numbers. So that's about a closure of about 300 rural practices. And when that happens, and you've got people that have to drive an hour to a hospital,
correct.
They're not going for preventive care. They're not going for that annual screening. They're just going to show up to the ER when it's a major issue.
That is a major issue, and that's another problem with access and delivery, right?
Yeah.
So when AMA asked the physicians...
Oh, yeah, these were good questions.
You saw this?
Yes.
Who sold their practices in the last 10 years, and why did they do it?
What was the number one reason?
There's a 70.8% cited inadequate payment, so that's reimbursement. We hit on that.
Okay, that makes sense.
64.9% say they wanted to improve access to costly resources.
Okay.
63.6% say they need help managing the payors, the regulatory and administrative requirements. That's the prior auths.
So those are everything that we've talked about. So they're getting low paid. That was reason number
Correct.
one. They needed access to costly resources, so everything has gone up in price, and they can't afford the equipment or the supplies or
That's
the
right.
DME. And then after that, they need more staff, and they can't afford that as well. So because of the denials and the prior auth issues.
Okay, so how does that affect people? And so when you move that much of the provider force into corporate entities, and we're going to get into private equity in a minute, but what happens... And I found this very, very interesting. What do they give up? And when you look at it, the Physicians Foundation actually surveyed this, and 67% of the physicians in independent practice, when they moved, reported they had significant autonomy in clinical decision making. But then when they moved, do they have that?
No. Well, it goes back to what we started this conversation with, and I forgot the number already, but it was the amount of time that these providers get to spend with their patients. I think that's ultimately when they give up. When you leave your private practice and go work for a big system, you get metrics.
Well, absolutely you do.
You get metrics like a restaurant or a bar gets their point of sale reports that show how effective you were, how much money you made, how much money you lost, what your average consult was.
So look, 67% of independent physicians said they had clinical autonomy. You know what that number is for hospital-based physicians, meaning employed physicians?
It's got to be much lower.
38%.
So half.
I mean, not even a half, a third.
Right.
So you're telling me that means 62%
because they have no
have
say-so.
no say-so, and that's how they feel.
They have no say-so. The scheduler could be someone out of state.
That's a huge gap.
It's a computer scheduling their clinic, so they have no say-so over, well, hold on a second. I know Rory's coming in, and he likes to talk a lot, so let's block off 30 minutes for him. No, Rory's appointment is blocked off for 6 minutes.
So then exactly. And then, of course, you walk in, and you've got, hey, I've got 30 patients today, and I've got 5 hours to see them.
And I haven't done any notes today.
Right. I can't have done my EHR, right?
And I have to come back tomorrow.
So when you think about it, 61% of employed physicians have limited also freedom to make referrals outside of the system.
Oh yeah. I see it all the time in the big hospital systems here where
they
it
have
says
to refer all in network.
All in network unless,
patient wants it or we don't have the services.
All the regulatory
Correct.
language, right.
All
exactly.
the buzzwords, right. And let me tell you, if they do refer, I guarantee you they're getting coached.
Oh yeah, absolutely.
They're getting a talk to by the principal.
Oh yeah,
they're going to be put in detention.
Hey, why isn't Conrad having? You referred him for surgery at this outpatient surgery center. Why isn't he doing it at the hospital?
They put him in penance hall, or even worse, they might even decrease their pay or the next year.
Yeah,
so
they shouldn't, but they will.
They will.
Yeah.
They will. And look, and here in Louisiana, we're watching this play out in real time. We have some of the big systems here, and I got to tell you, it's interesting to watch the movement of physicians in independent practice.
It's concerning. I think. They're talking about AI and speeding things up. I know one of our big systems has AI recording in the rooms now to help.
There's no more scribers.
There's no more scribers, and now you just have your consult and it records and goes into your record and the doctor reviews it. I think that's to help because they're scheduled so fast. But is it all really making it in there, or is it missing something?
So we have another option. Doctors have another option. So if you want to brave the world and independent practice, right? But you don't want to go in a hospital,
right?
But then say you want to finally get your golden parachute, you got private equity. You've ran the practice for 30, 40 years. Now this is geared to more older physicians.
Correct.
Because and this is very interesting.
Unless you get lucky and you start a practice, but you hit a home run, but it's most likely not
for our younger doctors and our sort of younger or mid-level doctors in terms of your age and seniority. You're not going to like this.
No, you're not, because now you're employed. You're employed by a mini hospital now.
You're employed by again metrics in your own private practice.
Yeah,
and a ton of metrics.
Yeah, look, it's a huge shift. I think.
What are we looking at number wise?
All right, so there's been a 6-fold increase based on private equity deals from 2012 to 2021.
That's
a
insane.
6-fold increase.
That is insane.
So there's been based on in 2025 there was 150 buyouts, 664 add-ons, and 214 investments. So global healthcare PE deal value hit a record of $190 billion last calendar year. $190 billion in healthcare
crazy.
Private equity
That's unbelievable.
deals. So now the model is typically the same that I'll let you kind of discuss.
Yes. So in other words, the modeling show. This is why the older doctors like it. They come in and you know this, you've seen this. It's a beauty pageant, and they come in and they tell these older guys, we're going to give you 13x, 14x on your EBITDA. Yeah. Right? And the older guy's like, whoa, what? 14x, right? And then, so they do the hook. They get him in.
They look at the books.
They look at the books. And
wait a second.
Wait a minute. We're going to go down to 7, 8x, right?
And we're going to pay off all this debt that we talked about.
And we're going to finance the debt through our payment to you. So that's now going to come down to maybe 4x.
And we're going to need you to stick around for like 3 to 5 years.
To help transition.
To make sure that all the patients stay. And if they don't all stay, we're going to need some of that money back.
So basically, when it comes down to the numbers, the private equity firm is putting up a fraction, right, of the purchase price because they're financing it through the debt.
It's all debt,
and then loads it on to the practice post deal, right? And so then all of a sudden, now you're working for a metric, on a debt finance deal. It's a marriage. It's a hell marriage.
Yeah, it is.
And most of these docs don't, especially the younger ones in the mid-level, because the senior guys like, man, I got 2 or 3 years. This is my golden parachute. That's great. I'm out of here.
Yeah.
Right? Terrible.
No, I think it unfortunately you'll see where there's been a lot of bankruptcies.
For the debt.
For the debt, because these private equity deals will come in, they'll buy it. The doctors realize this is a horrible deal, and then private equity doesn't care. They'll just sell it off and close the practice. And so now those doctors that built up in that community and their reputation and sponsored the little league t-ball teams, that's all gone.
They're gone.
All that stuff is gone now.
And so we're seeing a lot of this. Yeah. I got to tell you, it's really, really tough. And I don't know if the doctors are in the middle of it, And
it's the same concept with working for a hospital. You've got it's the same thing with working in the hospital. It's all about patient outcomes. When you've got private equity breathing down your back, they're going to tell you, hey, Conrad, I saw you spend 30 minutes with Rory today, and we lost out on 4 other patients that
could have been more higher reimbursed.
Yeah, we're gonna need you to, or you spent too much time with Rory. He was in for a hangnail. You should have spent more time with Joe because he needed surgery. That's what's going to happen to you.
And you're seeing that already. You saw the Annals of Internal Medicine saw a 13% increase in emergency room department mortality after PE acquisition.
Wow.
That's a lot.
Yeah. Yeah.
I mean, that's a lot. You talk about going after the dollar.
Yeah.
You
Oh,
know?
because they're going to buy hospitals just like they buy practices.
And that's not just the ED. So look, 11% increase in nursing home mortality after PE acquisition. And right now, just so you know, Louisiana has supposedly, and I haven't run the actual double check on this, but 27 PE-owned hospitals, second in the nation, allegedly. I didn't know that either.
Okay.
I have to look at it. I looked at the data. I'm like, wow, that is really interesting.
But it makes sense when PE comes in. They're going to run it leaner. They're going to have less people. They're going to have probably lower quality, equipment, machinery, DME, those type of things. It's all going to.
It's almost like the slum landlords.
Yeah,
that we hear
exactly
about. Right?
What it is.
The slum landlords, like literally Band-Aid and freaking duct tape.
Yeah, because it's cheaper. It's cheaper to the shareholders up top. So.
So look, I'm going to wrap this up. This was really important. I came to Rory this morning and I said, let's do something about the changes in healthcare over 10 years. And I could tell you, I don't know where the bubble's going to burst, but I could see the bubble now.
Yeah. I think that we're still going down this path where doctors are getting burned out. They're being asked to do more for less money in a quicker amount of time, and I want to AI is not going to be able to replace a doctor.
And I agree with that. I want to tell you this, and I want our listeners to know this. And we never really do this, but I think we're going to start changing this because I do get the questions. But if you're a listener and you're a physician and it's affecting you, and these things that we're talking about have affected your practice, affected you, you have some issues with navigating reimbursement strategy, prior auth problems in your practice, evaluating, contracts, even a private equity acquisition, call us.
Yeah.
Call Rory, call myself.
Yeah.
Because we're here to help.
Yeah, you come on the show, you can talk about it.
We could do that too.
Yeah.
We could do that too. And look, if there's a health law topic you'd like us to tackle in a future episode, we want to hear from you.
Right.
We don't want to just spill out our little guts. We want to hear what is important to you. And so you can reach us directly. You can head over to our website, www.shahardy.com. Reach us out directly if you want. You have our emails, our phone numbers. And look, if you found this episode helpful, give us that good 5-star rating on Apple, Google, Spotify, all those fun things. Until next time, thanks again for joining us on Health Law Talk. Have a great day.
Thank you.
Thanks for listening to this episode of Health Law Talk, presented by Shahardy Sherman Williams. Please be sure to subscribe to our channel, make sure to give us that 5-star rating, and share with your friends. Shahardy Sherman Williams is providing this podcast as a public service. This podcast is for educational purposes only. This podcast does not constitute legal advice, nor does this podcast establish an attorney-client relationship. Reference to any specific product or entity does not count as an endorsement or recommendation by Shahardy Sherman Williams. The views expressed by guests on the show are their own, and their appearance does not imply an endorsement of them or their entity that they represent. Remember, please consult an attorney for your specific legal issues.